Hello, everybody. Welcome to our rounds for January 2024. Today, we are very lucky. We have the Orillia Soldiers Memorial Hospital Regional Sexual Assault and Domestic Violence Treatment Center staff with us. They were established in 1993, and the Regional Center for Suspected Child Abuse and Neglect was added in 2005. The team is comprised of 5 registered nurses, 3 social workers, and 8 pediatricians, and they provide services to all people of all ages throughout the Simcoe County and Muskoka area. And I will let the ladies self-introduce themselves.
Thank you very much, Kathy. My name is Simone. I'm a registered nurse with our team, and this is Sue, and this is Krista, and they are social workers with our Regional Center of Suspected Child Abuse and Neglect. And so today we are going to give you some of the basics of our programs, what we offer, how to refer to us, and then we will be delving a little bit deeper into one of our topics near the end, and we will introduce the topic at that time. So I'm going to go ahead and share my screen, and we will get started. Just bear with me for a moment. There we go. So we would like to start with our OSMH land acknowledgement statement. Orillia Soldiers Memorial Hospital acknowledges that we are situated on the traditional territory of the Anishinaabe Nation. We would like to acknowledge the enduring presence of the First Nations, Métis, and Inuit peoples of this region, specifically the Tri-Council First Nations, comprised of Beausoleil First Nation, the Chippewas of Rama, and the Chippewas of Georgina Island. We also acknowledge the Moose Deer Point First Nation, the Wata Mohawks, the Georgian Bay and Moon River Métis councils in this region. It should be noted that the Wendat and the Haudenosaunee nations have also walked on this territory over time. As for disclosures, we have no relationships with for-profit or not-for-profit organizations, and this session and program has not received financial or in-kind support. So as Kathy said, we are the Regional Sexual Assault and Domestic Violence Treatment Center and the Regional Center for Suspected Child Abuse and Neglect. So that is kind of 2 different hats for one program. We have 5 full-time registered nurses who provide services for both the Sexual Assault Domestic Violence Treatment Center as well as the Regional Center for Suspected Child Abuse and Neglect. Depending on who they are seeing, the clients would fall under the different programs. We have 3 social workers, one specifically for adult and adolescent population under the Sexual Assault Domestic Violence Treatment Center, and then 2 social workers who work part-time in a different program. So there are a total of, I believe, 1 full-time equivalent for our Regional Center for Suspected Child Abuse and Neglect program. And then we also work with 8 pediatricians. Those pediatricians cover like their own practices. However, we do access the on-call pediatricians, and we do run a pediatric clinic every 2 weeks, and the pediatricians rotate through those, each taking their turn to run a clinic. We are a regional program, so we do cover as far south as, I'd say, Bradford. The next center south of us is Mackenzie Health in York Region. Up to Parry Sound is probably about the cutoff point. The next 2 centers north of us are Sudbury and North Bay. And the next center east of us is Orangeville, Owen Sound. So we usually go about as far west, not east, far west as Collingwood. And the next center east of us is Peterborough. So it is quite a wide geographical region. We are a member of the Ontario Network of Sexual Assault and Domestic Violence Treatment Centers. There are 37 centers with the network across Ontario, and you would be able to access that via the Ontario Network of Sexual Assault Centers website to be able to see which center is nearest to you if you aren't in our area and if one required services. So brief history, and Kathy did go over some of this. We began in 1993. In 1998, we began seeing domestic violence clients as well. 2002, we began seeing pediatric sexual abuse clients. And then in 2005, we began seeing pediatric physical abuse and neglect clients as well, under the auspices of the Regional Center for Suspected Child Abuse and Neglect. For us to be able to see somebody, they must consent to that service. The only exception to that would be if it is a child that Children's Aid Society or Family Connections in our area is involved and they are requesting an assessment. Even then, when we see children, they still do need to consent to the examination. If a child is dead set against an examination, we would never force that exam, but we do try to work with them to be able to get through that. But for anyone over the age of 11, so 12 and older, they have to consent for us to be involved. We see women and men who have been sexually assaulted. We see women and men who have been physically assaulted in an interpersonal relationship or an intimate partner relationship. And we see children who have been physically or sexually abused. So for referral criteria for the sexual assault and domestic violence portion of our program, have they been sexually assaulted in the past 12 days? Or has the client been assaulted by an intimate partner in the past 4 days? And can the client even provide informed consent? For example, are they under the influence of any alcohol or drugs that is making them not able to provide informed consent or not able to have a conversation or understand the information we are providing them? Do they have capacity to consent? So are they able to mentally able to understand the information we're providing to them, either due to disability, or are they able to make their own decisions, or potentially are they under a Form 1 and they need to be medically cleared mental health wise prior to seeing us. So generally that is a conversation that we have with the, usually we would like to speak to the physician at that point if they're referring them to us, just to make sure that assessment's been completed and that they are able to provide informed consent for our services. Emergency medical treatment always takes priority over evidence collection. So do they need medical clearance? For example, for their pain, for their injuries, or for any mental health issues? And does the client consent verbally to have a referral made to our program? The other thing they can do, especially since Parry Sound is a ways away, some people are not up to the trip to Orillia when they are in a merge, so they might agree to a follow-up call from us the next day to potentially set something up for to be seen not in the moment, but maybe the following day. And we will go over timeframes and everything for which our services can be provided. So if you'd wanted to refer somebody to our program, it would be through OSMH switchboard. The number is there. You would press 0 and ask to speak to the sexual assault or domestic violence nurse on call. We are on call 24 hours a day, 365 days a year. Questions we would ask is, do they have a safe ride to and from us? Are police involved? Do they have a support person to come with them? And obviously, do they consent to our services? Other things we'd want to know if they are under the influence of any drugs or alcohol, or if they need any medical clearance prior to attending OSMH. And we frequently, because we speak with a lot of emerges that are outside of our area, we might even talk directly over the phone if that's an option with the client, just to make sure we're assessing their concerns directly with them. what their biggest concerns are, so that we know if we're the most appropriate service for them, or we know how to plan for their care once they arrive. Some of the treatment options, if they do come to see us, we can do a sexual assault evidence kit. Police do not need to be involved for us to be able to complete that kit. We can complete a kit and store it for up to 1 year at our center while they decide whether or not they'd like to involve police. After 1 year, if we have not heard from them, we will destroy that kit. But the documentation that goes along with the kit will be in their medical record for 10 years after their visit, or 10 years after they turn 18 if they're younger than 18 at the time of the visit. However, the kit does not get tested at the Center of Forensic Science in Toronto unless police are involved. Only police can submit a kit to the Center of Forensic Science in Toronto. We can provide medications for prevention of sexually transmitted infections and HIV. So the STI prophylactics, the antibiotics we can give up to 5 days after an assault. The HIV prevention medication needs to be started within 72 hours. We can do a physical exam and treatment of injuries, pregnancy testing and prevention. Again, we would be providing Plan B usually within 3 days, and we can provide Ella up to 5 days for pregnancy prevention. And then forensic evidence collection. So that can be the kit, or that can be injury documentation and photography. Support and crisis intervention. Basically, that goes back to finding out what their concerns are, and if we're not the appropriate people to deal with that, then who do we want to refer them to from there? So we can refer to community agencies for counseling, as well as the social worker that we now have with our program, and the Sexual Assault Domestic Violence Treatment Center side of things. And then we would also provide follow-up visits for HIV prevention medication, STI testing, or just supportive phone calls to make sure that their needs are being met even after they leave our center. So we just popped this in here because not everybody wants to report to police, at least not right away. And there could be a lot of different reasons for that. Sometimes they've had previous interaction with police and it hasn't been positive. So they may not feel safe going to the police again. They may have reported an assault to police before and nothing was done about it. So they think, well, that was a lot of, stress and trauma going through that process. So why are they going to do that again and put themselves through that again? However, we try to support them with that. If they want to report to police, we try and support them through that. But it's always good to make sure that if you want to call the police while they're at your emergency center, to make sure that they're on board with that plan, or that plan is discussed with them first. Again, I don't believe there is a statute of limitations on reporting a sexual assault to police. Obviously, the sooner that police can begin their investigation, the better chance they'll get good evidence or good interviews. However, there is time, and that doesn't always need to be done immediately in the moment that they present to us or to West Perry Sound. So for domestic assault treatment options, injury documentation and photography, we do the Ontario Domestic Assault Risk Assessment for assessing risk, which measures recidivism, which I actually got that word on the first try this time, so that's impressive. And that's how likely the offender would be to assault them again. So sometimes that helps police in setting bail, or that can help give some perspective to the victim of the assault, just to kind of say, probably it's information they already know, but then it says in black and white what that risk is. And sometimes that can be a bit of an eye-opener for them if they are thinking about leaving the situation. We do safety planning with them. We can make referrals to a safe place so that they don't have to go back to their dangerous situation. We do make referrals to community agencies as well as our own social worker. We can do a mental health assessment. And if there are any needs in that direction, we would refer them back to our emerge for further follow-up, potentially with a crisis worker or an emerge physician. And then we do continue to follow up with them after their initial visit to our center. So this is just some good tips or information on recognizing intimate partner violence in the emergency department. When there are delays in seeking care, untreated chronic medical conditions, vague or inconsistent medical history, unexplained injuries or injuries are inconsistent with the history provided. And I feel like these are a lot of things that we see and immediately our red flag goes up anyways, because it doesn't make sense if, you know, you're in a merge, we do an x-ray, it discovers that your arm is fractured, and yet you've been having this pain for 5 days and you haven't sought medical treatment beforehand. There's probably a bigger story there. Also, for a physical exam that may include multiple injuries at various stages of healing, posterior rib fractures, defensive injuries, restraint injuries at wrists, ankles, and neck. And again, a lot of that, the history will not explain. The history provided by the patient or the client won't explain those injuries or won't match those injuries that are shown on their bodies. Multiple visits for the same presentation, chronic pain syndrome. So a lot of times people will come with abdominal pain or stomach ache that isn't explained by anything medically, mental health concerns, and substance use and abuse issues. So we had started universal screening at our hospital. It has kind of fallen off to the wayside a bit. But there is on our emerge face sheet, there is a checkbox that this person has been screened for intimate partner violence. And this is a routine standardized screening upon presentation to the emerge department, and anybody can do it. It is low cost, low risk, and highly effective. So you would ask questions like, do you feel safe at home? Because they can interpret that how they interpret it, and it's a bit more, you know, open to interpretation for the client. Do you feel safe in your relationship? Are you in a relationship that makes you feel scared? Are you facing any physical or emotional abuse? Do you fear for your safety? If any of these questions are answered in the affirmative, so if there's a positive screen, you can ask consent to refer to us or provide a list of local community agencies. I believe there is the Esprit Place in Parry Sound that provides domestic violence services as well. But they can always speak to us over the phone. We are available 24 hours a day, and we can help them navigate that as well. And I believe that you should have a poster in your emergency department. I believe we sent them out a year or two ago, where it lists our treatment options. It lists what we do. It says that everything is somebody like their own choice and that it's a consent-based program. And a lot of times the patients or the clients can take a picture of that with their phone so that at least they have those options, or they can talk about that. That can kind of open up the conversation between the triage nurse and the client about whether or not they require our services or would like to access our services. Okay, so we are going to talk a little bit more about the pediatric portion of our program. So that is under the umbrella of the Regional Center for Suspected Child Abuse and Neglect. So medically, we see children who have been sexually abused when they're 11 years of age and under. 12 years of age and older would fall under the adolescent adult portion of our program, which is the Sexual Assault and Domestic Violence Treatment Center. And then we see physically abused and or neglected children ages 15 years and under. So that's mostly because after 16 years of age, it's not really under the umbrella of CAS or Family Connections anymore. It would be more directly to a police investigation. they would be treated and emerge. And then it would be directed to police for the investigation and evidence collection and photography. However, we have done photos in emerge, even if it doesn't necessarily fall under our program. If it is like intrafamilial assault. But again, yeah, that's more generally directed towards straight to police. And then we provide counseling for verified physical abuse and neglect or sexual abuse for youth under the age of 16. And so when I believe we'll talk about this a little bit more, but when we say verified, it just needs to be acknowledged by CAS or Family Connections or by police that yes, they believe that this abuse or assault has happened, even if we don't have enough evidence to move forward with charges or move forward to court.
We just need to make sure that it's already been investigated and a decision has been made about services.
So just some of our stats for our Regional Center for Suspected Child Abuse and Neglect. Over the fiscal year of April to March of 2021 to 2022, in counseling, our counselors, our social workers saw 102 clients in 383 encounters. And medically, we saw 37 children acutely or urgently through emerge. And then in our non-urgent clinic, we saw 13 children. And I will talk a bit more about the differences between those two. And then from 2022 to 2023, our social workers saw 112 clients and 247 encounters. We saw 48 children acutely through emerge, and we saw 18 children in our non-urgent clinics. So for referring children to our program, we would want to know if the child has disclosed an assault. So if they are verbal, what have they said about whatever our concerns are? Is it a disclosure from them that has led to someone contacting our program? If they are nonverbal or if they haven't disclosed, then what are our concerns about abuse? Why are we concerned about either sexual or physical abuse? When did the assault potentially occur? And when has the child last had contact with the alleged assailant? If we know who that is, we don't always know who that might be. Is CAS or Family Connections involved? If not, they need to be called. Has the child been interviewed? We don't do any interviews, but to be able to see these children, we will have wanted that interview if the child is interviewable. We will have wanted that interview to have happened already, just so that we know what we're doing when we are assessing the child, if there is an injury on their body, what is the history of how that injury has happened, so that we know whether or not the history, we can give an opinion on the history matching the injury to be able to provide an opinion to CAS and or police. And then is the child complaining of any injuries or any signs or symptoms of anything? So if they are disclosing sexual abuse, are they complaining of any vaginal or penile injuries or pain or discharge or anything? So referral criteria for child sexual abuse under 12 years of age. Again, have they disclosed the abuse? Why are we concerned about abuse? Was it within the previous 72 hours, which would make it more likely to be an acute visit? And have police and family connections already been involved? And to be able to refer someone, you would want to contact us through OSMH switchboard. It would either be the registered nurse that you'd be looking for, or if you're an emerge physician and you've done an assessment on the child and you're looking to consult with the pediatrician, then it would be the pediatrician on call through OSMH switchboard. And then if the pediatrician needs to see the child and they might require me, then they would give the nurse a call. And then for the physical abuse portion, again, have they disclosed? Why are we concerned? Like, for example, with nonverbal children, if they have some suspicious bruising, or if they have bruising that isn't over a bony prominence, how has that happened? Sometimes police or CAS will want an opinion on those bruises, and then we may see the child after that. Are there injuries that require treatment? Was the abuse within the previous 72 hours? Are there visible injuries at this point for us to be able to document? And are police and family connections involved? So when we do an emergency assessment, they would triage through OSMH ER department. We will let them know that we are expecting somebody. If the CAS or police or another emerge department has called ahead for children 11 years old and under for sexual abuse, and children 15 years old and under for physical abuse, the assault has taken place within 72 hours or there are visible injuries to be seen. Also, if the child is less than 2 years old, we're more likely to do an assessment on them regardless of what we're seeing in the moment, depending on what the concerns are, just because those children are more vulnerable, being nonverbal. That the pathway is a little bit different for them. Again, always contact us at the hospital prior to sending the child to the emerge department. For our non-urgent day clinic, we run these about every 2 weeks. So it is preferable to see the children in the day clinic if there isn't a reason to see them urgently. They're seen at the Child and Youth Advocacy Center, which is off of hospital property. It's very comfortable space, very low key. They have a therapy dog there, which makes the children just so happy to be there. They always ask when they're leaving, when they can come back again, which is so amazing for us to hear, because we absolutely want them to be so comfortable that they would want to come back. So again, it's for children who have disclosed an assault occurring more than 72 hours ago. So for adults and adolescents, I'm not sure if I mentioned this, our window for evidence collection for a sexual assault evidence kit is 12 days. For children 11 years old and under, it is 72 hours. So again, the non-urgent clinic is for kids who do not have acute physical injuries or pain, and children for sexual abuse ages 13 to 15 years old are seen on a case-by-case basis, just because they are a bit older. Like post-pubertal is not generally what our pediatricians see. So depending on what the needs of those children are, they may be seen by an RN if it's a non-urgent case. And then again, these clinics take place approximately every 2 weeks. So for the urgent visit, what may happen is a well child exam by a pediatrician. The pediatrician would generate a consultation report giving some of the history, what they see on examination, and then their impression of what they see. Any findings in sexual abuse cases are interpreted by the Joyce Adams tool, which is a journal article. It's really actually very interesting if you do have a chance to look it up. The newest version is 2023. However, it lists everything that could be found vaginally or rectally, or just lists any type of, for example, redness or discharge, or and then it categorizes all the findings under whether this is a normal variant, normally seen on non-abused children, if this is more concerning for sexual abuse. So it's really helpful for the pediatricians to use that in forming their opinion. If a child is seen urgently, we can do a sexual assault evidence kit. We do photo documentation of mostly of every child we see, because we do consult with SIG kids regularly. We also do peer review every month, so then they can see what we are seeing in the moment when we review those cases together. We can do STI testing, STI prophylaxis. We can make a referral to one of our 2 social workers. and other community agency referrals as required. In our non-urgent day clinic, again, we would do a well child exam by a pediatrician with the consultation report using a Joyce Adams tool. Potentially, we do photo documentation. Usually that's more along the lines of if there's anything to see, including normal variants, just to make sure that we're all on the same page with sick kids in our interpretation of what we're seeing. We can do STI testing. We can actually meet with the social worker at the Child and Youth Advocacy Center, and then make other community referrals as required. Consultation is required on all suspected abuse cases. So we always need a phone call ahead of coming through eMERGE. If a child arrives in eMERGE without us having received a call that they are coming, they would be assessed by the eMERGE physician prior to being seen by our team, and then the eMERGE physician would consult with the pediatrician. So if whoever is referring them to our eMERGE can speak with either the nurse or the pediatrician first, it makes the process go a lot smoother for the family once they arrive in our eMERGE. And again, that's the hospital number, press 0, and then ask to speak to the sexual assault nurse or domestic violence nurse on call, or the on-call pediatrician if you are an eMERGE or physician or family physician. I am going to let one of our two lovely social workers take it over, and they will explain what they do.
Yeah, so Krista and I are the social workers in the program. We provide counseling to kids, service throughout the region of Simcoe Muskoka. We try to meet children in the area that they live. So we do some traveling and partner with community organizations to use space to meet with kids. As Simone mentioned, we provide service to verified cases, and either the verification has been given to us by police or family connections. And one of the reasons that it's really important that we're providing to verified cases is we need to know that we're providing service to a victim, because we are a victim service. We need to know that it's been investigated, and we also need to know what happened. And if we can gather that information from either police or family connections, then we don't have to ask the child. They can tell us if and when they're ready during the process of counseling, but we don't expect them to have to share their story again. So it's really important, as well as if more information comes out during our work with the child, we know what's already been, which was already been presented and interviewed and investigated, that if more information comes out during the counseling process, we know what we have to report. We get our referrals from a variety of different places. We work very closely with our partners, the nurses, whose office is right beside us. We work closely also with the Child Advocacy Center. We get referrals from family connections or DBCFS workers, family physicians, child victim witness programs, sometimes directly from parents or directly from police. Again, we have to make sure they have gone through with having their interviews and that the situation has been verified, depending on where we get the referral from. Our criteria is that the allegation must be verified, as I mentioned, that the child is under the age of 16, and parental consent must be given to children under the age of 12, and children must have no contact with the offender, as well as that the children would be showing some signs of symptoms of trauma, as well as when we're working with the children, they also must consent to want to come to see us. So that's important too. We provide short-term counseling, usually about 10 to 12 sessions. Again, as I mentioned, efforts are made as best as we can to provide service in the area where the child lives. We never provide service in a child's home. Ideally, we find a neutral space in another organization or a library. We've met in all different places. And during COVID, we were restricted to just provide virtual or phone sessions. That has lifted, and we still do offer virtual and phone if that's what meets the family's needs or the child's needs. But we are seeing more children in person now. As I mentioned, we have partnerships with various agencies to provide service, and we offer parental support and psychoeducation to parents. If the parents are struggling with issues related to themselves or being triggered because their own abuse history has come forward, then we would help support them get connected to counseling for themselves. That our counseling is very limited to providing support on supporting the child and psychoeducation about the trauma the child has been victim to. Our service is a crisis of disclosure support, so we get involved as quickly as we can. As soon as that investigation is done, we contact family and see the child as quickly as we can. We need to make sure that the child is in a safe place so that they can actually do some work in counseling. If they're not safe, then it doesn't make sense to them to be talking about how unsafe it is. We need to make sure that that place of safety is assured. Having no contact with the alleged offender, that they're having support from a non-offending parent. We do trauma-informed, trauma-focused lens. We do EMDR. We do all sorts of different therapy. We're very eclectic. Trauma-focused CBT, play-based intervention, mindfulness, depending on the child's needs, where they're at, the symptoms that they're suffering from. And our focus is really on safety and stabilization, and focus on relief of the trauma-related symptoms and processing the trauma if they're ready to do that work. And if we're working with a child and we've done our 10 to 12 sessions and we're really concerned about this youth, then we would connect with our community partners at a children's mental health agency to refer for longer term service. And we are available for those families if they need to recontact us, if there's something issues come up. We often find that once we've provided 10 to 12 sessions, some youth, that's all they need. And they're feeling like they've had an opportunity to process and talk about what happened, and they're feeling safe and stable, and they might need counseling again in the future, but they're feeling like the crisis is over and they're feeling like they can manage and cope. Yeah, so we have a local peer review with sick kids every month, like Simone mentioned. We often attend the Hospital for Sick Children's annual maltreatment conference. We're part of the network also, so we're part of the network social work program, and we consult with other social workers within the network who are also providing service across the province.
I think that, so we are going to switch over to our.
We do questions about that.
Oh, yeah.
I wonder just about, because that's
Good call. I'm going to stop sharing for a minute.
if there's any questions about our program.
So we are going to move on to the next portion of our slideshows. However, I just wanted to, I'll check the chat and just see if there are any questions. Nope, that is just from Kathy. So does anybody have any questions at this point about anything we offer, or how to make referrals or how to contact us before we go on to the next portion of our presentation?
Hi, everybody. My name's Dan. I'm an emergency room physician in Parry Sound.
Thank you for attending.
Well, thank you for doing this. That's all very good information. The quick question I had,
Yes.
if you could quickly touch on age of consent. I've had 13-year-olds disclose that they're in sexual relationships with similarly aged children. If you could just touch on this for us.
Okay, so I think we're talking about two different things here, because one is consent to be able to have sex with somebody else. So if, I'm not sure, because I'm pulling this out of the back of my head, this might be a CAS question, but I believe if they are 12 and under, they cannot consent to sexual activity. If they are 13 or 14, they can consent to sexual activity with somebody who is within 2 years of their age range. Actually, I believe that's up to 16 now. So if they're 15 and under, it has to be within 2 years of their age range. And if they're 16 and over, they can consent to sexual activity. Now, I know my colleagues are on here, so I'm not sure if one of you wants to pop in and correct me, but it's something along those lines. But for consent for us to consent to our program services. Generally, if they're 12 and older, I'm having them sign their own consents as long as I'm satisfied that they understand what we are doing. If they have a parent or a guardian with them, I have them sit in on that consent process so that they can ask any questions if they have any questions or concerns as well. They might bring up something that their child has not thought of, but we do try to explain it to the best of our ability, what it means. If they are younger, we may sign consent to complete a sexual assault evidence kit, but not yet sign that consent to release that kit to police. So at least we have the evidence. We haven't missed that window of opportunity, but they don't have to make that decision today or on their own about whether or not they want to report this to police. Does that answer?
Yes, thank you. I appreciate
Yeah.
that.
Okay, no problem. Oh, and my colleague has just popped on into the chat. 14 or 15-year-old can consent as long as the partner is less than 5 years older. 12 and 13 can consent as long as the partner is less than 2 years older and there's no relationship, of course, right? No relationship of trust, authority, or dependent. So not including soccer coaches, teachers, et cetera, et cetera.
Yeah, the trust, authority, dependency, all of that piece, it goes for all of those ages, so 12 through 15.
Perfect. Awesome. Thank you, Elise, for popping in there. That's great. And Kevin, do you have a question?
Yeah, thanks. Just for my own information, I don't think it's something we would really see very often out here. But anyway, so we're at the Argyle and PLC. We're kind of out in the middle of nowhere. Should we ever come across a situation like that? You mentioned that there is like a satellite network to you through North Bay. Is that right?
No. So I was just saying where the next centers are. So we ourselves are Orillia Soldiers Memorial Hospital. We fall under the Ontario Network of Sexual Assault and Domestic Violence Treatment Centers. There are 37 centers total in Ontario. We're one of them. So the next two north of us are Sudbury and North Bay. They also have sexual assault, domestic violence treatment centers. So we work similarly, but we're not necessarily connected. We can refer to each other if a client moves out of their area into our area or vice versa. So we work together, but we are our own separate centers.
Right. So now if a situation were to present itself, would we say to the patient, just go to Emerge, or would we contact that service directly and arrange for an appointment?
I would always contact the service directly because if the client arrives here at 2 in the morning and I don't know that they're coming, it's highly unlikely I'm in the hospital. But if you call me ahead of time and that client has a 2-hour drive, I'm going to be there. I'm going to be set up, ready to go. I'm going to be fully caffeinated, and we'll just, get through that visit a lot quicker than if I only find out when they walk in through Emerge. They're probably going to have about a 45-minute wait while I get up, brush my teeth, drive into the hospital, get stuff set up, and then I can provide services for them. So it's always best. And I would say that for any center, just to call ahead. Because I even like talking to the client myself. I let them know that everything is their choice. This is what we can do together today. Does any of that sound okay to you? If at any time you change your mind, then you can end the visit at any time, just to kind of give them more of that sense of control. So yeah, I would say always call ahead.
Okay, great. Just one last thing I'm curious about here now with regards to timelines for evidence collection. My thought on that, you mentioned, I think for an adult up to 12 days. My impression was that, if something were to happen, it's basically go right there. Don't shower, don't change your clothes.
No,
don't do anything.
absolutely. Best evidence collection is always as soon as possible. But if they are presenting 8 days later, And even if they have showered, but maybe they haven't like had their menstrual cycle or anything like that, evidence shows that we may still get some good evidence collection. I hope that court would take that into consideration if that kit is tested and nothing comes back on those swabs, that they would take that time frame into consideration, that that evidence may be lost. But when they do the research, it is possible that that evidence is still there. It's been shown. And so that's why they say if it is 12 days or less, to still do the evidence collection, just in case we may be able to catch something.
All right, very good. Thank you.
Perfect. No problem. Any other questions? All right, I think we'll keep moving. Sue and Krista are going to provide us with some information about something that they have seen during a bit of a rise in during COVID. And I'm going to let them go ahead and take over. That is very good information, but sorry, I've lost my, there it is.
Just a bit of a disclaimer. This is a topic nobody really wants to talk about and nobody really wants to hear about. And if it's too sensitive or it's hard to hear, then please take care of yourself because it is difficult information. We thought it would be important to chat about this topic because we did see an increased trend during COVID.
During COVID, and also just given this is a super brief overview, so we're just going to touch on some main points because there's lots there and we could fill more than 15 minutes for sure on this topic. So.
I apologize. I don't think I hit share screen, so sorry, I do have to go back.
Do you want me to try?
No, I got it. I just forgot. Sorry.
Okay.
That one. Oh, that's mine. We'll just share it and then I'll try and switch over. Can you see?
We still see you.
Okay, sorry. It's not showing up on my options here for sharing. There it is. Sorry about that.
Yeah, now it's up.
Okay, perfect. Thank you.
We kept you in suspense for that long and what we were going to talk about. We're here to talk about sibling sexual abuse. So when we started doing some research on sibling sexual abuse based on the numbers that we were seeing, Krista found this quote actually: when a man hits his partner, we call it intimate partner violence. When parents hit their children, we call it child abuse or maltreatment. When a child repeatedly ridicules his or her classmates, we call it bullying. Yet when sibling hits a brother or sister, we call it horseplay. So we thought that was really actually quite telling because sibling sexual abuse has been largely overlooked in it's not talked about, it's not even written about very much. We could hardly find any literature. And for most of us, it's even really hard to talk about. Most of the abuse literature and information that we've all been provided is information about adults hurting children and abusing children.
So like Sue said, there's lots of discrepancies even in the literature about the definition of what sibling sexual abuse is. We sort of settled on this definition, which says that it's defined as sexual behavior between siblings that is not age appropriate, non-transitory, and not motivated by developmental appropriate curiosity. And there's usually an exploitation of a power dynamic and some degree of forced activity. The term sibling can encompass a broad range, including biological, step, half adopted, and foster siblings.
And if you take one thing away from what we're chatting about today, it is the prevalence. So sexual abuse involving child siblings is thought to be the most common form of intrafamilial child abuse. And even for us who work in this field, we don't actually see it as often as it's happening. The research says it's perhaps up to 3 times more common than sexual abuse by a parent or step-parent.
And the reason for this, for it being underreported, is sort of shown here. So the first reason why is around complex relationships of siblings. Depending on their age and their size and the ability of the siblings themselves, the roles that siblings play, like older children being put in position of authority of younger ones, older children tend to be believed more than younger ones, and older children having a wider range of tactics just by the nature of them being older that they can use against their younger siblings. The environment that they're in also plays a huge role. Siblings are left in charge of others. There's increased unsupervised time together, closer proximity, so sharing bathrooms, sharing bedrooms, unregulated screen time, which we saw a ton of during COVID, exposure to intimate partner violence. And we know that just through COVID that there was an increase of intimate partner violence, and there's a correlation between that and sibling sexual violence as well. Parents tend not to report. Lots of different reasons for that. Not wanting to disrupt the family dynamics, not wanting the family to break up, having to choose between one of your children who to support.
Not wanting to believe that one of their children would do that to the other child, not believing the actions are harmful.
And then the bigger issue around perceptions of normal sexual curiosity. So there's a really wide range of belief around what normal curiosity or exploratory or mutual curiosity actions and behaviors are between siblings. And then, of course, if there's a previous history of sexual assault, families that have history or children that have previously offended are more likely again to offend again if there isn't any intervention.
And victims fear that they'll be blamed for it if they tell. And most educations that kids are getting in schools or anywhere is about adult abuse or somebody in an authority situation. It's not talking about what's maybe happening from their sibling. And most kids don't even understand what's happening or understand that it's not okay. They don't want to disrupt the family, like Krista said. They don't want to get in trouble. They don't want to get their sibling in trouble. And they don't want anybody to know about it. And unfortunately, children are often left feeling alone and frightened and not knowing what to do.
So this slide is just a good overview and a description of sort of what is a normal sort of sexual behavior and what would be considering sibling sexual abuse. On one end, more sort of kind of exploratory, is mutual. There's not that power dynamic. And then of course, on the other end, it would be highly intrusive, repetitive. There's that power over and authority. And I think the characteristics that's defined in the literature is including sibling age range differences anywhere from 2 to 5 years of age. Again, that power difference, and other characteristics such as size of children and their abilities. And then the behaviors themselves, like I said, forced acts or repeated acts.
And again, just a quick review of the research that we did, and it was fairly brief, but in most sexual abuse cases, the perpetrator seemed to be the older brother, older stepbrother, or the male as a perpetrator, and the victim being younger female sibling. But that isn't always the case. We had, in our experience, we've had males with males and females with females. So again, the literature is sort of says that there's a bit more of a tendency to be older brother, older male to younger, but we saw differences. We didn't see consistently that.
And so even just in the cases that we've seen in the last, like through COVID up to now, we did see a drop in cases through the middle of COVID. And that was just because kids were not in the safe places where they would normally disclose. They were at home with those who were doing harm to them. So even in 2020, we had 75 cases. 13 of those were sibling assaults. And then it dropped down to 6. That's like half, and then down to 1, and then down to 4. So I think as kids are now more out back at school, back in the community, developing those relationships again with their teachers and who they feel safe with, to be able to disclose what's been going on at home.
But those 13 cases, that was a bit of a rise for us. And we were chatting with other social workers in the network who were also seeing that increase in numbers too during that time.
And some of the things obviously that would have contributed to that, the increase in isolation, increase in unsupervised time with siblings, increased screen time. There was one training that we were at, the research from Pornhub said in 2021, there was an increase in watching pornography by young youth, and the most watched category was step sibling videos.
Yeah, which we were surprised and bothered, and yeah, but that's.
So since most children don't disclose sibling sexual abuse until they're adults, the Center of Expertise on Child and Sexual Abuse made the following practice guidelines when working with adults in the capacities that we do. So, and again, this is all the trauma-safe, trauma-informed care. So safety, being warm and welcoming, respectful, consistent, and predictable with our patients that we see, building up trust, providing reliable and clear information, maintaining confidentiality, talking about choice, so helping people to gain autonomy, the skills they need to take control of their lives, and what directions that they want to go. Working in collaboration together, paying constant attention to the ways in which the power of the professional and the vulnerability of the service user may be inadvertently reinforced. So trying as best as we can to stay neutral and supportive, and of course offering a strength-based approach.
Providing trauma-safe environments may mean that those who have experienced sibling sexual abuse aren't required to disclose their abuse verbally in order to receive sensitive care. And there's evidence that in those environments where professionals are perceived as sensitive to and having awareness of child sexual abuse and its consequences may encourage people to share their experience of abuse that have happened in the past whenever they're ready. I guess we just kind of wanted to bring this to your attention. You may be seeing this in the ER. Again, we might not be seeing it. We're seeing it not that much, but the trend over COVID certainly increased and brought it to our attention. And we're learning that most people don't disclose until they're adults.
So again, super brief. Not sure if there are any questions and whether we'll be able to answer them.
And again, we did want to keep it brief because we do have just that, 1 hour to give you all this good information, but there's a lot of good information that Sue and Krista sorted through and kind of picked the best that would be probably the most helpful for those here attending today. So we hope you found it helpful, interesting, maybe something to keep your eyes open for. It is disturbing, but also we need to know about it so that, if something raises our red flag, we can reach out to CAS or Family Connections or our program just to kind of say, hey, this doesn't feel good to me. If you're seeing something in your family practice, then you know that you have people that you can reach out to get, further information or further consultations on that. There's a really good question. Is there a website or a handout for future reference? There is
that reference list.
Yeah. Can we, Kathy, could we email that to you? Are you able to distribute that?
I can, yes.
Okay, perfect. We will email that to Kathy and then she can distribute that to the attendees. Good question. Thank you.
Any other questions? Did you want to put up your phone number again? Maybe in the chat in case anyone wants to
grab that.
If anyone wants to ask a question, you can go ahead and unmute. Not seeing anybody unmuting, raising hands. So I think you've
And-
done an excellent job. Oh, go ahead, Simone.
Sorry, just to point out as well that Sue and Krista are not accessible via the 24-hour access. They are Monday to Friday office hours. They do evening appointments if that suits the family. But a referral to them generally would come through us, but that can be also during daytime hours. But you can always reach us at the hospital number, press 0 and ask to speak to the sexual assault or domestic violence nurse on call. And that can be for adolescents, adults, or children. You can say RCSCAN as well. But depending who you get at switchboard, usually they're more familiar with our SADV hat than RCSCAN. So thank you to everyone for coming out and listening to our presentation today. We really appreciate the opportunity to share all of this information with you.
Well, thank you very much for coming back once again and presenting to our team, sharing
Excellent.
resources with us. And
No problem. We love to do it.
I hope we can have you back again in the future.
Sounds good, Kathy. We'll be in touch.
Okay, sounds good. Thanks,
Great.
everyone. And just for those who are still here, February 22nd, we have Dr. Patel. He's a lifestyle medicine physician.
Great.
Thanks.
Thanks, Kathy. Bye.
Bye.